We are live, and welcome to another episode of the Machine Medicine interview series. And we are lucky to have Andre Brunoni here today. Welcome, Andre. Perhaps you'd like to kick off by just giving us a little bit of background on what you currently do and how you got into that position.
Okay, so thank you, Jonathan. Thank you for inviting me to be here today. It's a pleasure to be here. So, as you said, my name is Andre Brunoni. I am associate professor at the University of São Paulo Medical School. I'm currently director of the Service of Interdisciplinary Neuromodulation at the Institute of Psychiatry, and also director of the ECT service at the same institution. I started working at, so I'm a psychiatrist by nature, and I did my PhD in brain stimulation with Felipe Fregni at Harvard Medical School. And ever since when I returned to Brazil, I started working with brain stimulation. During my PhD, I did a trial combining tDCS, which is a form of brain stimulation, with sertraline. And we were interested at that time in the combination with tDCS with antidepressant drugs. We saw that the combination was more effective than each therapy alone to treat depression. Then we did a second trial, which was during my young investigator phase to compare the efficacy between tDCS and a full dose treatment with escitalopram, 20 milligrams per day. And in that treatment, we saw that escitalopram was more effective than tDCS, but tDCS was more effective than placebo. We did some analysis afterwards that I think we are going to discuss about that afterwards. But then again, afterwards, I did a postdoc with Frank Padberg at Germany at LMU Munich. And then I returned to Brazil again, where I got faculty position as an associate professor. And ever since, I started running my own lab, and then I expanded my interests to do TMS as well, to do ECT as well, and expanding a little bit my techniques, and now entering in this world of precision psychiatry and precision medicine.
Cool. Thanks very much for that, Andre. Really interesting. And perhaps it'd be helpful for us to talk a little bit about the general kind of clinical issue of depression and how big a problem is it, how many people have it, and have you got any thoughts on the sort of degree of success that we've had in the past? You mentioned a couple of what I guess would be considered the mainstay of treatment nowadays, SSRIs. Be interested to hear your thoughts on how psychiatry sort of features in the sort of the gallery of diseases.
Yeah, so always my main interest has been on depression. Now in adult depression, now we have some works in geriatric depression. We are also planning some studies in adolescent depression, but let's stay in adult depression for now. So the adult depression is the second, depending on the statistics, is the first or the second cause of disability, considering all causes of diseases, and not only mental disorders, but physical disorders as well in the world. So regardless if you are in a high income country or a low and middle income country, is one of the three most important causes of disability. And that's because it has a high prevalence. So it's about 20% of people will have a depressive episode in a moment in their lives. It has symptoms such as low mood and anhedonia. Anhedonia is lack of pleasure to do things, which highly affects quality of life. So imagine people with low pleasure to do things and low mood. So these symptoms will affect quality of life. These people will not want to work. These people will not want to enjoy things, and this affects not only personal life, but also in terms of work and all these types of things. And also, treatments for depression are only moderately effective. So we have like big studies such as the STAR-D study that showed that after several lines of treatment, still 30% of people remain depressed. So 30% of people are refractory to antidepressant treatments. And truly, STAR-D was done 20 years ago. Now we have more effective treatments or more or newer treatments, but we still know from a clinical perspective that basically still nowadays, or maybe until recently with the advancements of precision psychiatry, maybe the scenario will change, but basically until now, the treatment is basically a trial and error process, and we still have very high refractory rates in depression.
Yeah, so an absolutely colossal problem.
Yes.
And some treatments for it, but actually in many people, although in some people they are very effective, in many people they are completely relatively ineffective, and we don't really have any clue why it works in one person and not in another. So yeah, that's really helpful, and it sets the background a little bit. You mentioned also you mentioned drug treatment, but you also mentioned a couple of other treatments which are interesting to sort of note in passing. I suppose I think you also mentioned that actually you run the service for ECT in your own institution. Is that right?
Yes. Yes.
And that's a sort of interesting therapy that's often used in people that are treatment resistant with respect to drugs and stuff. Would you consider that a form of neuromodulation, or do you think it's a?
Well, that's a very, very interesting question, because ECT was the first, let's say, non-pharmacological modern treatment, or it was not a modern treatment. It was developed in the 40s, but it's very, very highly effective, and it's still used nowadays. And basically, it was considered that its effects was based on the convulsive effects. But then when it was more investigated, we found some interesting things. So basically, imagine two people having exactly the same type of seizures. So the same duration, the same EEG recording or readout. But basically, depending on the positioning of the electrodes, so for instance, depending if it was unilateral or bilateral, it would induce different clinical effects and different adverse effects. And this is basically because the pattern of electrical field stimulation. So different evidence pointed out that the pattern of the electrical field induced in the brain would lead to different clinical effects. And this is a very strong indicative that it's also a neuromodulation therapy.
It's super interesting. So let's just unpack that a little bit, because I think there might be some things that wouldn't be super clear for people. So as you mentioned, ECT developed in the 1940s. It's electroconvulsive therapy. It's fairly crude, right, in its basic sort of principles. It's that you have electrodes across the cranium, and by passing actually relatively significant currents from one to the other, you can induce a generalized seizure, right? A generalized epileptic seizure, which then spreads throughout throughout the cortex. Is that right? And that was what, and you were saying that initially the therapeutic benefit was attributed to that generalized seizure that was induced. However, when you look at the data, and it turns out that the location of the electrodes appears to be important for therapeutic and side effects. Is that right? And therefore, that would tend to argue that the generalized seizure, which by definition is everywhere, was not the or at least was not the whole story, but the location of the charge delivery was actually crucial as well, which makes it sound much more like a modern day neuromodulatory kind of transcranial sort of.
Jonathan, that's exactly what you said. So it's electroconvulsive therapy. Some people say electroshocks. We psychiatrists, we don't like that because it's associated with stigma, but it's basically using a very strong AC current to induce seizures. Of course, with anesthesia, with sedation, but basically electricity inducing seizures. But the same seizure with different patterns of electricity will induce different clinical effects. And that's why we think that it's a novel form of neuromodulation. And in fact, there are now different forms of convulsive therapies. We have one type of convulsive therapy in our service, which is named magnetic seizure therapy. Basically, it's a form of seizure therapy using strong electromagnetic fields. So it's a mix between transcranial magnetic stimulation with ECT, basically a very strong transcranial magnetic stimulation that will induce seizures, and this will bring clinical effects as well, but without inducing adverse effects, because the seizure will be more restricted to the cortical area without inducing seizures at the hippocampus. And so it will bring clinical gains without inducing memory side effects.
Right. And I remember as a student learning that actually the memory was always a concern, but actually one of my professors, I remember telling me actually the data suggests that people actually improve in terms of cognitive performance after ECT. However, there's a strong suspicion that that may just be the motivational changes that happen before and after treatment. Is that right? But here you're saying, is there now additional evidence that actually sparing the hippocampi may actually result in benefits, or at least the absence of harms that might otherwise be delivered? Is that right?
Yeah, so ECT actually improves most of the cognitive tasks, or cognitive tests, but there is one test of autobiographical memory that actually is impaired in ECT. That's the one, and that's because the current passing through the hippocampus kind of damages, so to speak, like kind of impairs the capacity of hippocampus keeping memory, or keeping or functioning in terms of autobiographic memory, and this can be a side effect of ECT.
Right.
And depending on the positioning of ECT, so again, if you do unilateral ECT, then you have less impairment in terms of autobiographic memory. That's why this is now the standard nowadays, not bilateral ECT, but unilateral ECT, but still new forms of seizure therapy are being developed. And one type of treatment that we are testing now, which is magnetic seizure therapy, might preserve the clinical gains of ECT without inducing this specific type of adverse events. But you are right that in terms of general executive functioning and the general cognitive performance, there are clinical gains using ECT. And basically because people with severe depression are so much impaired in terms of cognition that when they improve in depression, they will also improve in terms of cognition. Yeah.
Gotcha. Okay. So that's really interesting sort of Cook's tour we've had of depression, what a major problem it is, and some of the treatments that are available that are already a bit like neuromodulation. Drugs are typically, though, the mainstay, and there's a couple of interesting things about them which are curious. One is that they, as you mentioned, they're not effective for everybody. Another thing is that somewhat curiously, perhaps, they seem to take up to 2 weeks or more to actually have a clinical effect, and there is, I think, some suspicion that that may be to do with it takes time for a sort of neuromodulatory effect to alter the dynamics of brain circuits, and therefore we get an effect. Then is that a reasonable kind of characterization of SSRIs, at least?
I would say that a very minimum would be 2 weeks for SSRIs, but typically it would take 3, 4, or even 6 weeks. So there are more epidemiological studies that says, for instance, the study showed that in a significant portion of patients, maybe 20-30% of patients, you would have to wait up to 12 weeks to see full effects. Yeah.
Okay. Cool. All right.
So just to complement, and of course, thinking that you have to escalate to a full dose, right?
Of course, you generally start on a lower dose and right up. Brilliant, and that kind of brings us into a reasonable sort of segue into your work that we really were keen to talk to you about today, and in particular, the use of the several different neuromodulatory approaches to depression, of course, but in particular, you've been focused on the transcranial direct current stimulation. Would you like to say a few words about how the differences and similarities with the kind of things we talked about, like ECT, obviously a much smaller hammer?
Yeah, so I think there is a very large umbrella of types of neuromodulation, and they are in different sides. And there are even like the invasive types of neuromodulations, of course, DBS, VNS. I would say that ECT and MST are perhaps minimally invasive types of neuromodulation. And then we have the non-invasive. We have, of course, the big brother, which is TMS, and then we have like the baby of the techniques, which is tDCS. It's not the most recent one. If you go to the literature in the 60s, there is a very similar method, which is called brain polarization. If you go to the history in the 1900, so in the 1880s, so in the past, so 200 years ago, there was also a form of galvanic stimulation that there are similarities with tDCS, and you can see descriptions in the British Journal of Psychiatry of this form of galvanic stimulation 150, 200 years ago. But the modern methodology of tDCS was developed in the early 2000s. The first form of using tDCS in depression was done in 2006, actually, in a small trial here in Brazil with of Felipe Fregner and Paulo Boggio. And basically, it's interesting because it's a form of brain stimulation where you use low current, direct current stimulation through electrodes put over the scalp. And then there is a direct current induced from the anode to the cathode. So from one pole to the pole, you have a positive electrode and then a negative electrode. And then there is a current induced from one electrode to the other. Because there is a deflection in the skin, in the skull, and then also in the fat layer, the current spreads out. So there is a very large area that is stimulated. So it's the most non-focal of all the brain stimulation methods. TMS is much more focal, for instance. So there is a large area that is stimulated. It has a very low intensity as well. So there is these main characteristics from a more physiological point of view. But even though it was shown from several studies, so Michael Nietzsche is one that studied a lot from a physiological perspective. Maron Bixon from New York is one that studied a lot from in vitro and from a bioengineering point of view as well. We studied it from a clinical research point of view. So many studies showing that it's effective. It has physiological effects, and it has clinical effects as well.
Right. So just to recap a couple of those points. So it's direct, in contrast to say ECT, which you mentioned was an alternating current, so a rapidly polarizing, depolarizing current. This is a direct current, so it's actually a continuous. And is it being modulated typically, the pattern of either the voltage or the current, or is it being changed, or is it typically a continuous sort of?
It's continuous. Of course, you can combine. It's possible to combine DC and AC. So you can combine any type of pattern. But what we use basically it's DC, and so you have like kind of a field of more a positive field near one electrode and a negative field more in one electrode. So there is one field near the anode, which is more depolarized, and one field near the cathode, which is more hyperpolarized. So so we say that anodal tDCS depolarizes and cathodal tDCS hyperpolarizes. Of course, this is a very mechanistic point of view, and of course only considering the device perspectives. And of course there is huge variability in terms of the subject, and it's not always like that, but from a mechanistic it's like that.
And it presumably, as you said, that the volume of affected tissue is very large, and it includes superficial cortical structures, but also deep nuclei of the brain. Would that be correct?
Yes, so that's correct. And that's an interesting thing, because TMS, it's more focal, but it penetrates just a few centimeters, and tDCS, it's less focal, but the circuit has to be closed. So it passes through everything until the current is closed. Of course, if the electrodes are too close one to the other, then the current shunts. But if there is enough distance, of course, there is some shunting through the skin, but the current that penetrates, it goes through even deeper structures. And now we have very modern studies doing simulations of electrical field modeling. And there is validation. So Maron Bixon and others did validation using studies in animal, but also studies in people with DBS electrodes, basically doing tDCS in these people, and with DBS capturing the amount of current, and they saw that there is electricity passing even in very deep structures.
Wow.
So it passes through even deeper structures in the brain.
Fascinating. All right, and then we're finally sort of getting to the guts of your paper, and so this particular paper was a reanalysis of a study that was done previously, and essentially, if I can try and characterize my understanding of it,
yes,
you took a data-driven approach to clustering in order to try and divide the depressive patients. All these patients had major depression, major depressive disorder, and you used a data-driven approach on the basis of the standard rating scale that is done, one of several, but a fairly standard and widely used one. You took that data, used it to cluster the patients into 4 different groups, and then looked at if there was any difference in their responsiveness to placebo and escitalopram, again a very widely prescribed SSRI, and then transcranial electrical stimulation. Is that right? And
yes.
Anything else to add? And what were the sort of basic findings?
So I would just have to explain the main paper because it was a reanalysis. So our main paper was published in the New England Journal of Medicine, and basically it was a non-inferiority design with placebo. It would take like 40 minutes to explain why we use this design, so I will not go through the details, but basically we had 3 arms. We randomized 94 patients to tDCS, 91 to escitalopram and 60 to placebo. And basically our main findings was that escitalopram was superior to tDCS, which was superior to placebo. And it was, we were happy, so to speak, that tDCS was superior to placebo, but not so happy that escitalopram was superior to tDCS. And then we went through secondary analysis, so it's important to remember that was post hoc, these findings. And we wanted to look for specific types of symptoms that maybe tDCS could be superior to escitalopram. And this comes out of the beginning of our discussion that depression is very heterogeneous. So we might have two people that have symptoms of depression that they would not be similar one to the other. And then we look for recent literature, and then we found the work of Adam Shekrut, who in 2017 did a very interesting work, which was also reanalysis of STAR-D and other big studies. And basically what he did, as you said, was some kind of clustering, actually was a technique named hierarchical clustering. And basically he got the HAM-D scores and other scores in his work. And basically he clustered the symptoms of depression in 4 groups. So there was an atypical group, and then the psychiatrist hearing us, this has nothing to do with atypical depression. It was just a name that he has chosen, but has nothing to do with what we call atypical depression. There was the core depressive symptoms, which everyone has, because that's what's supposed to people with depression having, basically depressive mood and anhedonia, as we said. Then we had guilt/anxiety, and then we have sleep/insomnia symptoms. And basically he did his analysis. Basically we did the same clustering, and then we did the analysis of these clusters in placebo, escitalopram, and tDCS. So this was really in the context of precision psychiatry and in the framework of personalized medicine. And what was very interesting is that we found that first, a validation that escitalopram was very good in improving anxiety symptoms, and that validates decades of experience of clinical experience as a psychiatrist, because that's what we see. I would say even that escitalopram is even better in treating anxiety than depression, because it's really good for treating anxiety. But what was very novel is that tDCS was really good in treating sleep or symptoms of sleep and insomnia. And we didn't have statistical power to show that tDCS was superior to escitalopram on that, but there was a very strong evidence, or like a trend of evidence showing that, because tDCS was superior to placebo and the escitalopram was not superior to placebo. So there was some kind of evidence suggesting that tDCS was almost superior to escitalopram on that. So this would indicate that patients with depression and with important symptoms of sleep and insomnia, you might indicate tDCS and not pharmacotherapy. Again, this is post hoc, this is a secondary analysis, but something very promising and maybe an indicative of treatment in clinical practice.
Yeah. So one of the interesting things about is that this is the HAM-D rating scale that you mentioned, is the Hamiltonian or Hamilton rating scale, right? Hamilton rating scale. And I was having a read about it. One of the things that I read was one of the criticisms that's often leveled at it is that it does include sleep quality and insomnia as one of its components, and therefore a treatment could appear to be an effective treatment for depression, and yet it only improved the symptoms of insomnia and sort of other sleep associated issues. Obviously, sleep and depression are not unrelated and intertwined in certain respects, but have you any thoughts on that? Is this the best rating scale for depression, or is that not really a well-formed question? Does it depend on?
I would unpack this question too. So I would say it's not a good scale at all. It was developed in the 60s with another conception of depression. So it's not a good scale. There are better scales nowadays, but it's the scale that everyone uses, so that's why we still use. But I would say that the criticism nowadays of is particularly of these sleep symptoms is because many antidepressant drugs have as a side effect inducing sedation, you know. So many antidepressant drugs induce sedation. So it would be like as an adverse effect showing improvement. And that's definitely not the case here. So tDCS doesn't induce sedation. We don't see this as an adverse effect. So I would say that in this particular case, it's not valid. For many other antidepressant drugs, I would say that, well, this makes sense. There are many, I will not mention them, but for 80% of antidepressant drugs, they induce sedation. This would make sense, but not for brain stimulation particularly.
Got you. Okay. So as you said, it's a secondary analysis. You know, one always has to be cautious about things that hoc analyses. However, there's some very promising looking suggestive sort of data, at least, and it really sort of echoes with this whole concept of trying to characterize patients in a data-driven way without strong sort of preclinical preconceptions or hypotheses, driving things too much, and then potentially prescribing treatment on the basis of patient subtypes, and ultimately one can imagine even trying to characterize the patient much more richly on the basis of brain dynamics and imaging and so forth. So what are the next steps in sort of pursuing this thesis and this approach to precision psychiatry?
So I would say that we did other analysis that we didn't have the time to discuss here. So one thing that we are doing is doing secondary analysis, of course, because we did this big trial. We collect lots of secondary data. So we have some interesting analysis on neuroimaging and then doing electric field simulations of electrical field density. And we see, because of this huge variability in cortical folding, and also because this issue of tDCS is spreading out over a large part of the brain, we see that there is huge variability between subjects in the pattern of this distribution of electrical field density. And we see that this can predict many physiological outcomes, many cognitive outcomes, and so there is a strong line of evidence that this might predict clinical outcomes as well. So we think that's a promising line of investigation as well. And with so that's one line. Another thing that we are exploring now, changing gears from personalized psychiatry to digital trials. That's one thing that we are also interested. That's doing large scale trials, but instead of doing personalization, which is very cost intensive because you have to do neuroimaging, you have to do omics, you know. So it's basically using portable TS devices, ship them to, for instance, 1,000 person and assess them digitally. You know, basically collect data using passive data via smartphones, using ecological momentary assessments, doing stimulation via portable devices. So it's another concept that we are also trying to explore, and maybe that's another way of acquiring data. So we are exploring two philosophical concepts, you know, either collecting large scale data via digital trials, and also in our lab exploring more intensive data. And I think these two concepts will merge eventually.
I was going to say they don't seem mutually exclusive, do they?
No, they are both technology intensive, and they will merge eventually. Yeah.
Cool. Well, yeah, we'll look forward to seeing those next steps come into reality. We've gone a little bit over our apportioned time, so I do apologize for taking up more than we said, but it's just so interesting to hear about this study and the various issues around it. So thank you very much for your time, Andre, and we'll look forward to your future sort of projects and publications.
Thank you, Jonathan. It was a pleasure to be here.
Thanks a lot.